Good afternoon, everyone. Welcome to this section of webinar. I think it was this is how much time is. I think it's 14th webinar. No, it's not 15th. We have run this webinar actually. Won't go too frequently. So today we are great honor us to have our speakers, Fang-Fang and our moderator, Professor Yang Ruijie. I will first introduce Yang Ruijie, Professor Yang Ruijie, so he can moderate the whole webinar. Professor Yang is the Vice Director of the Peking University Third Hospital in the Department of Radiation Oncology. Professor Yang has been published more than 100 peer-reviewed papers and more than 10 book chapters, and received 10 research grants as the principal investigator of CoPI. Professor Yang's team developed the beam orientation and architectural optimization algorithms for IMRT and non-covalent VMAT, quality assurance techniques for external beam radiotherapy and high-dose brachytherapy and cis implant. So also deep learning-based method for multi-modality images synthesis, structure segmentation, treatment planning, and the QA for radiotherapy. So Professor Yang, the team lead the IAEA RCA International Collaborative Program in Medical Physics for education and training and certification, and also registration to improve the quality and the safety of the radiation medicine in Asia and the Pacific regions. As the leader of country coordinator, he was awarded with the American Brachytherapy Secondary HDR Brachytherapy Scholarship, the Seattle Prostate Program Fellowship. So let's welcome Professor Yang Ruijie to moderate today's webinar. Professor Yang, it's all on you.
Okay, yeah, thanks. Thanks, Professor Jin's introduction, and also for the invitation for this webinar. So now I will introduce our speaker, Professor Fang-Fang Yin. Professor Fang-Fang Yin is the PhD DABR Fellow of APM and ASTRO. He is a professor and director of medical physics graduate program in Duke Kunshan University. Is the distinguished professor of radiation oncology, Duke University, since 2004 to 2023, the chief of radiation physics division, Department of Radiation Oncology, Duke University Medical Center. And he was the member of AEPM and also for ASTRO, the International Society of Radiosurgery, a member of Radiosurgery Society, and also the Society of Directors of Academic Medical Physics Programs. Professor Yin's research experience focused on the imaging for radiotherapy, big data analytics, AI, and deep learning for the quality and safety, and also for optimization of MRT, AGRT, and treatment planning optimization, and also the treatment assessment of stereotactic brain and body radiosurgery. So related to the topic today, Professor Yin is also the graduate student's advisor, and also for postdoc and physics resident supervision. He was the awardee of Hall of Fame of the North American Chinese Medical Physicists Association He has many grants and grant reviewers, and also editorial services for the well-known journal in our field, including the Red Journal, and also for medical physics, and also the associate editor of medical physics. Professor Yin has chair or co-chair many APM task group reports and many patents. There are more than 300 peer-reviewed publications and about 20 books and chapters. So that's a brief introduction. We all know our respected Professor Yin. So now we welcome Professor Yin. Professor Yin, please.
Thank you, Dr. Jing, for having me in the this teaching series lectures. And I thank you, Dr. Yang, for your very nice introductions. So today, I'm going to discuss some topic related to radiomics and deep learning and AI applications for lung cancer diagnosis and radiation therapy. And this has been an interesting research topic and pretty hot for the next couple of years, and will be even hotter than it is for the next decades. And I think that will change the practice of our medical physics, change the imaging and radiation therapy, and potentially will change the scope of healthcare, both in China, in the Asia countries, and also through the world. So I think it's very important. I don't think I will be able to cover everything. I will basically to touch some of the applications and what we need to pay attention when we apply for these applications. So we all know that we're starting from cancer cells. Our target is cancers. Cancer, the diagnosis, the cancer for the treatment. And we needed to understand how the cancer was formulated and developed, and how it can, then we can really develop technology and medicines to overcome or to kill the cancer cells. This shows the pictures of how the cancer cells was formatted and the uncontrolled growth become the cancer cells, which are hurting the normal people functions and activities. And if you don't cure it, it will lead to your death or the other problems. The radiation plays the critical roles in cancer diagnosis and the therapies. And as we all learned from radiation biology, the radiation will have both physics process, the chemical process, and the biological process, and how cancer will be killed. So we need to continuously remember that our end point is the cancer cell killings. And this goes through the physics, chemistry, and the biological processes. Now, this needs people to work on this, and we need to learn the treatment for cancer can be a surgery, can be the chemotherapy, drug, and the target therapy, immunotherapies, and radiation therapy, which is depending on the where you are, the percentage may be different, but in the advanced developed countries, about 60% or more people will receive one way or the other format of radiation treatment. More importantly, we certainly need to learn the combination of radiation therapies. So because this is a medical physics societies and organizations, I really want to introduce that by understanding about what the medical physics is supposed to be. And I think medical physics should be a combination of the clinic, industry, and research development. that combines the multiple disciplinary specialties. And we think that the medical physics should including 6 distinguished areas in which we are working on, from radiation therapy, imaging, nuclear medicines, radiation biology, radiation protection, and engineering physics, etc. So those are very critical, and we need to educate the people through these areas. So that's why in the US, the pathway to be a clinical medical physics is you start medical physics PhD and the master degrees. And then you get the clinical training. And then if you are not in the medical physics areas, you can get a PhD in other related field. And then you take a medical physics certificate program and then become a medical physics qualified to be the clinical residency. Then you will go through 2 years residency clinical trainings. However, you don't have to go to be the clinical medical physicist, and you can be the physicist with non-clinical areas. That is the 2 end point for all the medical physicists. But if you are doing the research in any directions, you can do all this stuff. However, if you want to be a good really developer, understanding the core of medical physics and go through the clinical process, that's definitely the important area. For this reason, Duke Queensland University, we offer the master degrees for 2 years studies, and you get the master degree from the Duke University. That's the courses we are offering based on what we teach us. Now, we'll talk about artificial intelligence. The artificial intelligence has been a buzzword for everybody, everywhere, every country, every corner of the world. But AI is a kind of topic that everyone will be reading. But radiomics is that part of the AI? Yes, it is, but it's a little bit different because they extracting traditionally the perform the feature extraction and analysis. So that's why the Venn diagram they draw it in this way. They are not including inclusive everybody, everything, but they are partly involved. So we talk about deep learning, machine learning, and AI. So machine learning AI is part of artificial intelligence, and deep learning is the core in the artificial intelligences. Now, what the important thing is AI is basically learning and problem solving. And that's the very simple definitions. But to us, as a medical physicist, when we understand the definition, but also we need to know how to use this informations, the tools, the technologies. So my understanding, and from many literatures that stated that, if you want to be the expert as AI in medicines, or AI in medicine, or whatever you think that using the deep learning in medical applications, you should have 2 knowledges. One is AI knowledge or deep learning technology. The other is the clinical expertise. If you're missing clinical expertise, you will not be able to good applications for AI technologies. The second part is that we really need to validate whatever clinical models you develop for application in the clinical environment. Not only one hospital, one data set, but multiple hospital, multi-data sets. And I had many experience from the hospital that they have a model works only for this way, but not for the other ways. So what is radiomics? Radiomics basically is a process they are extracting feature and to understand something that you can see from the picture, but not from visions. The first thing you have to understand where the picture is, and then you identify which part you want to understand, is a tumor or lung. And then you calculate the features, we call the feature extractions, will represent the quantitative informations And then you're using the deep learning or machine learning technology to build a model to help you to make decisions. In this case, how to make decisions using radiomics, deep learning, machine learning played very, very critical roles, and that drive the success of the radiomic applications in the medicines. So AI radiomics has been used widely in every aspect. And as I mentioned before, that AI radiomic application has to be combined with a specific size. And personally, I believe that if you do the lung cancers, you have to develop AI applications specific to the lungs. So that's why I start to say the AI application for the lung cancers, and you including the screening process, that the imagings, genomics, proteomics, microbiomics, exhale, breathing information or lung function informations, and then for diagnosis, detection, malignancies, and imagings, histopathology, cytology. Then you're helping to make decisions, approaches, medication selections, the treatment selections, and also the treatment assessment. This is the general process for radiomic and AI combined applications. And if we do the radiomics based on the imagings, the imaging has to be harmonized. We call the image pre-processing. This is including many steps. And traditionally, you can using the ROI features, and that's what we call the conventional handcrafted engineering features. But on the other way, that radiomics feature could be also extracted using deep learning technology. We call the deep features. Or you can combine these two features together and to perform the decision and diagnosis and the predictions. So this is important practice that we all are interested to learn from the practices. So in the radiation therapies, and almost every aspect in the process are using AI applications. Right now, maybe some in the clinical, majority not in the clinical yet. But I guess that in the next 5 years, your clinical medical physics practices, operations could be replaced by AI technologies. So we have to think about how to translate our job responsibilities, how to quality assurance AI softwares, and how to improve the quality, safety, and efficiency for the radiation therapies. And all those are in progress or implemented or under development. So the one thing we have to really keep in mind, everything you do, we should have a platform. The platform allows you to develop all the algorithms, all the structures, and all the methodology. So we should have those kind of structures to develop. And this is what we developed about 10 years ago. We built a data warehouse for the input informations. And that picture has been drawn for 10 years that we, including patient informations, radiomic informations, dosimetry informations, I call dosiamic info features, and then we include the genomic information. That time, we don't have every informations. We're mostly working on the images, but those are the future directions which we need to work on. And we needed to collect the patient data, the outcome data, and then define a clinical endpoint, either overall survival or recurrent or whatever overall goal is. So that needs another database. So we need a two database to including input information and output informations to build the models, and then we will be able to validate and test the models. So some applications has been, if you don't mind, mute your speakers. Okay, so there's many applications that's 4 or 5 years ago, Medical Physics published a paper to discuss deep learning in medical imaging and radiation therapy. That was a very in-depth review discussions. I thought it was worth to mention some of them, especially this is the disease categories from retrospective data. I think this is really, really good, the classification algorithms. They input the images and find the disease areas and categorize the different disease categories with the really, really good clinical efficacy for clinical applications, because this will be substantially improve our real clinical workflows, and also potentially will enhance or improve the ChatGPT type informations for clinical consultation and the studies. So the disease categories from retrospective data, that was a really good algorithm that they developed. The other important thing is, for example, is we do a lot of screenings, for example, for the male, for the lung cancers, and for female to do the breast cancers. So the algorithm has been developed to look at that, whether a computer were able to help radiologists to improve the readings and then all automatically to do the performance. This is an algorithm developed using the really modified the YOLO V3 algorithms. And this algorithm not only just to detect the potential masses, but also localize how big the mass is and where it is for the radiation therapy purposes. And amazingly, the algorithm with a deep learning with advanced computations, and you will be able to detect and identify the location of the lesions within seconds. This is very, very critical, especially with the performance metric score is 87%. That is really good, and definitely is beyond the typical radiologist can perform. So that's the promise of using the radiomics. On the other hand, when you detect the lesions, and if you have a mass, for example, there's a non-small cell lung cancer. Typically, they have two types, is adenocarcinoma or squamous carcinoma. So when we do the lung CT images, there's a potentially different type of image. If you do the breath hold CT images, you can free breathing CT images, and you can do an end of the average CT images from the 4D images. So we calculate radiomics for all three types to look at whether computer is able to classify those lesions into these two categories. And we're using the clinical histology as the gold reference data, and they build machine learning algorithms. And then the performance was very interesting. If you do the average intensity projections, the results was relatively poor with area under curve AUC is only 0.57. But when you're using the breath hold, and it's increased to 0.76. Certainly, this data is very limited with 97 patient cohort. But the results is very statistically significant. That indicates that even when using radiomics or using the AI technologies, we definitely have to look at what images you input. You cannot compare the image with average intensity projection with the breath hold or with the free breathings. That result is very different. So when we use it for the lungs and for livers, that is something that we have to pay attention to look at. And then the next step is we need to look at the lung functions. Lung function is very individualized, and then each person you have to base on what information you get, and then you can look at. If we get the lung images, and then if we want to do that, will be to some degree it's unsupervised, because you really can't you can supervise, but you cannot supervise well if individual breathing pattern is different. So we calculate this, and then we analog this each radiomic features calculated for lung, considered as in the physics world as quantum mechanics wave functions. And the wave function have different dimensions. The bottom line is that the lung function is a transition from one level to another level, just like a way in the nuclear physics, we have a potential well, and you have to reach to certain energy level, then you can be jumped to the different categories. So we're using this analog information, using the Schrödinger equations to get the potential functions, and then using the all the features radiomics we calculate as wave functions. Okay, the Schrödinger equation, the vectors. And then we added Radiomics dynamics to set the threshold so that we can find the different categories. And the results was actually quite impressive. If we don't add the Radiomics dynamics, it's a random, very difficult to classify different categories if we classify them well. In this case, we actually did pretty good that we got all these informations. Then when you do the CT images, the imaging dose is very critical. How to reduce the imaging dose. And then we need to customize, individualize the patient. So, this team, they have developed towards personalized imaging in image-guided radiation therapy. So they generate image based on patient size. So they are not overdose, not underdose. And this is another AI application to automatically decide based on one single exposure levels. So image guidance, AI is also helping to improve the image quality. And this is typical UNet architectures. And they modified this and to modify, improve the image, especially the scatter corrections. This is supposed to be the image for the perfect situations. But when you underdose, you get the scatter with all this CT images, and you got this will impact your quality of diagnosis. But when you apply these architectures, and you get very good results with the image compared to the reference. And the same for the lungs and for the other part. Back to the lung function again. And for radiation therapy community, we all want to know what's the lung function. And the lung function is not only overall, but some part may lung function well, some part may not function well. So in this case, we need to, not FEV1, but we need to spatially find out the lung function distributions. In this case, we can using radiomics or deep flow features to calculate the in the pixel-wise level to calculate the lung functions, and then to get the radiomics features to compare with the PET and the SPECT images. So this is what we find out. We got the calculate the Spearman correlations analysis between the PET and the SPECT with the we calculate the lung function, and we find out the gray level co-occurrence matrix and the gray level run length matrix. Find out the run length non-uniformity and the sum average. These two features plays critical roles to define the lung functions. So this gives us some indication that the spatial distribution of lung function is a potential calculable from the CT images that you may not need to do PET in the SPECT images for radiation treatment planning purposes. And this is another unit harmonization of the radiomics features. And typically the CT reconstruction with artifact may be not so good for radiomics analysis. But we need to harmonize that. So we develop so-called the 3D symmetric residual convolution CNN network, and to uniform harmonize the images, not only just enhance, but also harmonize images. So they make the radiomics calculation is much more uniform, okay? Everybody is start using the radiomic, the deep learning for image segmentations, especially to draw the organ at risk for the treatment planning purposes. This is actually very promising for some results, but what the people feel like the results is it's kind of puzzled that how they get the results and what plays the role and what algorithm. So we really need to develop a deep learning algorithm that is explainable. And that's another critical part is deep learning technology need to be explainable and also interpretable. Interpretable is more related to the algorithm. The explainable is more related to the processes. In this case, we're using a visualization tool as a process of interpret the results. And for this is like a glioma brain tumor segmentation with a FLAIR T1 contrast enhanced T2 images. And then we find out with a graphic visualization that the T2 images with the FLAIR images plays more critical roles in the image segmentations. With this, give the physician much more confidence that more look at the T1, T2 images to segment the results. Then the next question come out that you get the AI algorithms and what are you going to do? Okay, the artificial, like we do something, we judge something. Sometimes I'm very confident this is wrong, this is right. And sometimes I'm not sure, maybe this is wrong, this is right. So for the computer algorithm, we should also let the people know which part has more potential. Algorithm is not quite sure whether it's right or wrong. So in this case, we need to uncertainties quantifications. The algorithm should tell us that which part you are not certain, then the physician or the physicist can spend more time to draw it to do something. So this is the algorithm which we developed to estimate the uncertainty visualizations by one of our PhD students did. So they tell that, okay, this part is not quite right, and then you pay more attention or using other technique to prove it. The treatment plannings applications. The treatment planning, some are very easy, some are very complicated, and it's also depending on the treatment planner, how skillful you are, okay? So ideally, the machine is more uniform and they will not bias to the emotion and also the training, all this stuff. How good your algorithm is. So what we developed starting from knowledge-based and then deep learnings, and we got a bigger database. Database means that for this specific treatment, which is the best plan we have, we put all together as a learnings, and we extract that those symmetric parameters and the image features, and as an input and the output to build a model to learn. And after this model is built, and the new patient come in, we also extract the features we needed, the contours, and then those prescriptions, and the beam moderation informations, and then we will automatically come out the intensity map to calculate this. This is, we start to do that at the Duke a long time ago, more than 10 years ago, and it was results quite impressive. And I'll give you an example for the breast calculations. And for the ECOM, electron compensator technique, sometimes you have to, with this algorithm, you have to manually to modify intensity maps. And if you're adding all this time together, it takes a long time to do that. But if you're develop the AI technology, which we are using the clinical internally, and it only take 9 minutes. So compared to this, the efficiency, the quality is really substantially improved with the deep learning technology, artificial intelligences. This is very substantial. And with this, and the results is very comparable, but time is much shorter. And the other technology that used for the brain tumor, right now it's kind of standard practice with multiple masses in the brain. If you do radio surgery, and the patient outcome and the quality of life will be much better. So multi-mats, single isocenter is the technology used widely, at least in United States. And this actually take quite time. So if you're using AI technology, it can reduce from hours down to the 10, 15 minutes to finish it. So that is another applications. And another applications for clinical trials. And I had the opportunity to serve as a physics PI for the NRG, TOG, spine radio surgeries. And you see when you receive the plan is very different. And so the University of Michigan help us using the developer model using auto planning. And we find out if we use this, well, probably the clinical trial and the uniformity will be much better. So this is something that I think that all the clinical trials should be using this technology, which we regret we're not really using in the past. The other is that after you do treatment, radiation treatment, or maybe before treatment, you should understand if I'm using radiation therapy, what's the survival or what's the recurrent potentials. So we did some study. We find out that the local recurrent is more predictable, but metastasis is more complicated to develop. Now, this is only based on our studies, and maybe the further development applications could do better. The other thing is that if you just do the radiomics, not including the other part, the performance may be worse. So in this case, we did the radiomics, we did the patient informations, and we got the deep features all together. And then we find out that the performance is substantially better when you incorporate all the informations. And that gives us another hint that if you're purely using one information, may underperform the results. But the big model, big data, data harmonizations, that is very critical for the future development. So I think many algorithms are available, but we really need to look at it before clinical application, are we at the optimal positions. And for example, how to incorporate genomic informations. In this study, we did analyze the 24 patients with advanced lung cancers. We took the liquid biopsy and at the 2 or 3 weeks intervals, and combined with the response and the patient. And we find if you predict the overall survival just using genomic information, in this case, the mutation mainly in the happened the P53, it's only got to this level. If we're using the radiomics, it's very comparable. So radiomics get the results this, genomics get this, but combined together, the performance is much better. So that means that the multiple information really helps to improve the diagnosis and the predictions. Changing the physics, back to our physics. We spend a lot of time to measure the MRT QA, VMAT QA. Can we, using the machine learning or deep learning, to replace the patient-specific QA? The answer is yes. And there's multiple institutions has been working on this. So I would guess that in the next 5 years, patient-specific QA will be deep learned and will be not doing all this measurement anymore. So is that perfect world? Probably not. We do all these applications, but the quality assurance of the image and the methodology is very critical. We have not quite done the standardization of image acquisition parameter between hospital, even in one hospital for one patient. We have not done standardization on image post-processing. Reproducibility of radiomics features is not always checked. Radiomics phantom is not always being used. Robustness or modeling with radiomics is not quite understood yet. So how to get this done? What we really need to understand is the reproducibility and the consistencies of the application, either deep learning or radiomics. So we really look at to check the image systems, and also we really should look at the software packages. Imaging system package, we should have a phantom to test unifier, and from the physical and software hardware, and also we should have a phantom to check the digital phantoms. Now, this is one of the example done by a team in the, I think published in this paper by using the CT phantom. They develop a phantom and using the different technologies. And they're using this phantom with different medical devices. And they look at all this stuff. And then what do they find out? That the certain parameters they have been tested and they've been looked at this and to see the differences. So this is the electronic phantom or the physical phantom that will be used to unify the data acquisitions. And hopefully the deep learning technology can be also used to replace this so that the people don't have to shift the phantom to this. So our team in the a couple of years ago, we developed electronic phantoms to test the radiomics consistencies and the radiomics features. And we have a bar phantoms and also this noisy, and we call the kind of like a ball type of stuff to change the difference. And we tested the bar phantom and with the correlations with all the features. Those are all the phantoms which are the results that we think can be used to develop the phantom of this step. So a few more slides, and the people start to question that artificial intelligence will reduce the need for clinical medical physicists, and that was published in the Applied Medical Physics journals. I personally don't think this will reduce the need for clinical medical physics. I think it will enhance the need for medical physicists, but in much broader spectrums for these applications. And you should really be prepared and to look at that, to learn something different rather than just to do MRTQS. So current limitations of the AI and radiomics applications, there's many limitations. And here is just a few of them. There's a lack of high quality, high volume, longitudinal standardized outcome data. And that data is very limited. A constraint that is further exacerbated by the competing need for strict privacy protection. Some countries very strict privacy rules. You cannot get the data to build a box. So additionally, the black box nature of AI needed to be resolved. And I think currently there are some technology to do that, and but not everybody is doing this yet. The more important, there's a big mismatch between actually capability of AI and what does the physician or the clinical professionals want to see, what AI should do, and how to help them. That includes the ChatGPT and the other stuff. So those are the basic some limitations that we have, and we need to work on this stuff. So in summary, I think that AI and radiomics is an emerging and a rapidly developing field, which uses the extracted radiographic features as biomarkers for disease diagnosis, prediction, and treatment assessment. The application of AI radiomics in medical physics have demonstrated encouraging results. The results are very encouraging, but not for fully clinical use yet. It may change the diagram of medical physics practice paradigm in the future. So I think everybody should be engaged, and we really should pay attention about the quality assurance for applying AI radiomics. So the next important task group will be published is AI, machine learning application, quality assurances. So thank you very much. I stop here.
Yes, thanks, Professor Yin, very much for your excellent presentation. So covered the whole workflow of the treatment of lung cancer as an example, from the screening, the lesion detection, the diagnosis, individualized treatment, and also including some specific topics in our radiation oncology and medical physics. So our audience online can put your question in the Q&A section. So I think it's a very good opportunity because Professor Yin has very rich experience in this field and also in this topic, radiomics and AI for radiation oncology. So now the first question is from Dr. Banfas Yahaya. So the question is, what is the actual difference between radiomics and deep learning in terms of data volume, sample size?
I think that this is excellent questions. Okay, data volume size. I don't think there's too much differences in terms of radiomics and the deep learnings, because the radiomics at the decision levels, that is using the machine learning, deep learning technology to make decisions. And if you're using deep learnings and at the same categories, so the very much decision level is using the machine learning. So I personally, I don't think the data volume, the size has too much difference. However, I certainly have not really tested yet, proof it that this is very equivalent or exactly the same. But my experience from our previous study that even we're using radiomics, if radiomics results are not good enough, it's not because of the data number difference. We often see the difference between using deep learning and the radiomics single applications, but that's not related to data. It's more related to how you calculate the features.
Okay, thanks for your answer. And actually, I also have the similar question in terms of the sample size. So I see in your presentation, there's a very good study on the lung cancer radiomics platform for the patient survival or recurrence prediction. So the input include the patient demographic data, the image, and also those omics. So for such kind of studies, what do you think about the sample size to get a solid conclusion?
That's very classical questions. I think that's the big question from everybody, and everybody is looking at this. So our judgment, I don't want to generalize the answers. Okay, this is what our experience is that if anything under 100 data cases, we have to really very specific to the learning processes and the validation number sizes. We have to play different role to see whether any changes and how sensitive to that. So we tested the sensitivity of the data number using different learning technologies. Sometimes we adjust the number of the training, testing, and validations, and some with different technology. If the results come out very consistent, then I think the data is good enough for reach our conclusions. So that's typically the way we do it. So we're not really looking at the I think this is very specific to the tasks. But the way we do it is to using different way to learn, to validate, to test it. And that if they come out very similar results, then we think this database is large enough. And but sometimes it's only not that good. Then we are putting the certainly the best classification technique available.
Yeah, very good, very clearly explained. So there's another question is, can radiomics features be extracted directly from CT images?
Can you repeat it again?
Can radiomics features be extracted directly from CT images?
All the radiomics features certainly is, I don't know what do you mean directly? All our radiomic features extracted from CT images. The CT images basically, certainly you calculate the features, depending on how you define the features. So you have a different formulas to calculate it. But all the features is calculated from the CTs. And especially for the radiation therapy purposes, we're using CT much more than others because the CT is used for treatment planning. If CT can provide necessary information for your purposes, we will not need to do the MI or the other images. So yes, our answer is yes, it will be extracted from the CT images.
Thanks. So the features can be extracted from CT and other modality images. So perhaps there's many open source available publicly or in-house developed software can do that, right?
That's very good questions. I think any algorithm can be used, but before you use it or first time use it, you should validate with your validated software, because radiomics features could be very different with the same name from different softwares. And we did this study and we actually published that. It could be very different. So you don't want to use different software for one study. One study should be using one software, and that software should be tested before you use
it. Good. Thank you for your answer. And there's also another question coming. Can we use same algorithm for extracting radiomics features from MRI, CT, and PET images?
I don't see any reason why you cannot using the same features for calculation for MRIs, PET, and I think the same technology can be used, algorithm, but which one is more useful, how it's useful, you need to be very carefully analyze.
Okay, thank you. So I also am interested in the suggestion you mentioned at the beginning of your presentation on the AI era for the medical physicist training and education. So you have listed several core courses and elective courses. So do you think we need to think about to include AI related knowledge or practical skills in the training of medical physics program or resident?
Personally, I think you have to include this, and we encourage all the faculty in the every courses to including one lectures to discuss about AI application in these areas. There's a certain two ways. There's also, we have elective courses for data science and machine learnings. So that is another way to do that. The third way is we have our seminar courses. 50% of seminar courses are related to the AI, not principles and applications. So that yes, the answer definitely should be because the medical physicists, the next 5 years, if you don't know the AI, you may have a difficult to keep the jobs.
Yeah, right. Yeah, very good.
I'm not harassing
very
you.
good. Yeah, right. So due to the time limit, we come to the last question. Is there any clinical software for clinical purpose for radiomics? Clinical software.
I think there's actually very little. Okay, there's some companies that are sailing on this, but mostly are not commercial. They are more in the research and the clinical trial levels. I think radiomics for clinical application, there's a lot of work need to be done and how to be QA. And I was in the RTOG discuss about the using the radiomics to define the surgical margin of the brain and other stuff. But we see some challenges. So I don't know whether that's a commercial margin, but I see the investigational tools that some institution is using.
Okay, thank you. So if our audience have questions for this webinar, perhaps we can keep in touch with Professor Yin through the AFOMP training committee. So now I give the floor back to Professor Jin for his summary for this webinar.
Okay.
Yeah, Professor Jin.
Thank you. Thank you, Professor Yang, for your wonderful moderate, and also thank you, Professor Ying Fang, for this wonderful talk on radiomics. Actually, I think this is a very hot topic currently, radiomics and deep learning. And as he mentioned, we, as a medical physicist, we all need to master kind of AI technology in order, to keep up our job and keep our activities and I think opportunities. So thanks again. Thank audience for participating in this wonderful webinar. Our next webinar, called SCORE webinar next month, is on April 20th, so Saturday afternoon. We will have 3 speakers on the radiology, CT for our radiotherapy. So basically radiology technologies for radiotherapy. As for the audience mentioned, the register for the quality points, we have a continuing education points for this webinar. And we were actually, we don't need to share the speakers currently. We were based on your registration record before this webinar, and then we also have some recorded attending minutes, your online minutes for this webinar. So we were based on this information to send you the certification card. So lately, our scientific committee, our American John, he will send this certification. I think that this webinar is, today we have over 100 participant audience online. So it's very wonderful and productive webinar. Thank you again. Thank you, Professor Yin, and thank you, Yang. I think we are close today. See you next time. I hope in the future, we will invite you to take other activities for our webinar for AFOMP.
Happy to. Thank you, Dr. Jin.
Thank you. Thank you, Prof.
Thank you.
Okay. Thank you, Dr. Yang. Okay.
Thank
Thank you, everybody.
Bye-bye.